So maybe a comment in myelofibrosis, there is a prognostic scoring system. There's the Lille score and a new sort of consensus scoring system. So people with, the high-risk prognostic scores, particularly those who are transfusion dependent, those are the patients that we consider for allogeneic transplant. I'm not sure if Serge wants to make any other comments.
We see quite a few patients with myelofibrosis in leukemia department, about 150 new patients every year for the last 3 years, so about 3 new ones every week. And of course, this is disease of the elderly. Usually they are in late 60s, 70s. You do discuss the case of transplant with every patient, but the minority wants to go to the transplant. And our numbers are, in terms of the number of cases transplanted, are very low, like 12 to 15 patients a year. So it's worth exploring. Of course, this is the curative potential with the valuable effort. Toxicity needs to be reduced. We are engaged together in curing this disease, so hopefully with the introduction, for example, of a JAK2 inhibitor pre-transplant to reduce the spleen and improve the condition of the patient, we'll have more patients to undergo procedure and have better results.
And then in CML, it's I think we're all struggling to try to determine just where in the course of the disease we should recommend transplant, because clearly after they've transformed to a blast crisis is too late, yet many are responding to the second and even third line TKIs. And so we're working with Dr. Jabbour to try to identify high-risk candidates in that context. I don't see any further comments.
Well, with the use of the new generation up front, we can select early on patients who are really resistant. So if you start somebody on dasatinib or nilotinib and they don't hit the milestone like CCYR by 12 months, I think they should go for transplant if they have a donor. So the new generation can select early on patients who will be referred to transplant compared to imatinib therapy.
Okay, we're over time, but we'll take one question.
Okay. Sorry. But with the JAK2 inhibitors, how long do they work? With the TKIs, they seem to continue to work forever. The JAK2s, do people ultimately break through, or how often does this happen? And if they do, shouldn't that be a reason to transplant them earlier, and when they have their optimal response and when they can benefit from it?
Excellent point. So the longest follow-up is of the patients on ruxolitinib engaged in a phase 1-2 study, which started in the summer of 2007, and average follow-up now is about 3.5 years. We enrolled 107 patients, and after 3.5 years, 54 are still taking the drug. About 12% are off because of a loss of a response in judgment of a treating physician's eye. There is no real definition for loss of response. Okay. The others for different other reasons. These are elderly sick people who had to come back for therapy. So I would say half of the patients have a response lasting for 3 years. And you are right in the assessment of the utility of the drug as a pre-transplant therapy to improve the condition, reduce the spleen. My experience is that many patients get so much better that they would like to postpone the transplant because now they enjoy life again. Go fishing or whatever they do, and they don't want to do the transplant until they lose the response. And sometimes that's too late. They do lose response. So it's a, again, balancing act between the benefit and risk of different approaches.
I have a small question. The patients who have exon 14, the regular kind of JAK2 mutation, plus exon 12 mutation, having 2 mutations. I know they are going to be a minority, but are they any different from the regular patients?
These cases are quite rare. Yeah. They exist, but there are very few patients that are described, so that does not allow to see a clear difference until now, just due to the numbers.
Okay, well, thank you. We're over time, so we'll stop, and we're happy to take questions out in the hallway from you.